Motivational interviewing to Doctorate of Nursing practice students to address prescription opioid abuse in the older adult population. Okay, for those of you not familiar with motivational interviewing, it is a patient-centered counseling approach where a provider guides a conversation with patients to elicit intrinsic motivation to positively change behaviors by exploring and resolving patients' ambivalence. MI is helping a person motivate an individual to change their behaviors, their high-risk behaviors, for their own reasons. Motivational interviewing is an evidence-based behavioral intervention that has been used, had a wide variety of applications to include diet and exercise, smoking cessation, substance abuse, treatment engagement, medication adherence, and risky sexual behaviors. It's also been found to be effective across the lifespan from pediatric to geriatric patients. Motivational interviewing can be used in any healthcare setting. It's actually ideal for primary care, as this is a major point of contact for many patients. It's also time and resource feasible, with a trained clinician being able to provide this intervention in as little as 5 to 10 minutes in only a few sessions. So it's very useful in situations where patient's contact is limited, and it's designed to produce rapid, internally motivated change. So the problem that we're seeing is currently the Institute of Medicine reports there's an insufficient supply of mental health and behavioral health services available. So these are the specialty services that address behavior change. So a lot of this burden is now falling to clinicians. These are medical doctors, nurse practitioners, physician assistants, to address behavioral change for these high-risk behaviors that are increasing individuals' risks for morbidity and mortality. But however, unfortunately, there are barriers to clinicians addressing behavior change. Part of that is time constraints. They're working with very limited time face-to-face contact with patients, and also educational barriers. Typically, motivational interviewing is not a major component of a clinician's educational curriculum, and there's not a lot in terms of continuing education as far as addressing behavior change with these brief interventions such as motivational interviewing. So we really want to address clinicians being unprepared or not as prepared as they could be to address behavior change counseling so that we can improve these risky behaviors and decrease people's risk for morbidity and mortality. So there have been a few studies that have been done on clinicians where they incorporated motivational interviewing into the educational curriculum. Most of these were on medical students. They have shown improvement in learning outcomes. In addition, some of the feedback that they were receiving from their students is that it's increasing awareness of the clinicians, the students, that of the importance of addressing behavior change and how important this is in terms of decreasing risk and improving the health for individuals. To date, no studies have been done with advanced practice nursing students. So the question is, how do we educate these students on motivational interviewing? So a number of studies that was teaching motivational interviewing used the standardized patient simulation to educate the medical students, and it showed promising results. So these studies that used the standardized patients showed that it was effective in improving students' knowledge, their clinical skills, their psychomotor skills, and their communication skills. The use of standardized patients is an educational strategy that's highly supported in both medical and nursing literature. And again, it has been found in other situations, not just in education of motivational interviewing, to significantly address learning outcomes, improve upon them. So what is a standardized patient simulation? So a standardized patient simulation is a scenario that involves an actual person who portrays a patient that the students can interact with. The standardized patient is trained to present a scenario in an unvarying manner. So this is where the standardization comes in. The patients are trained for a high degree of realism, and it allows students to be presented with a realistic clinical setting or situation in a safe setting. So a scenario that the students will most likely see in clinical practice, but in a safe setting where we're not compromising patient care for them to practice their skills. This type of standardized patient can be used as a teaching method. It can also be used as an evaluation method. And it's also useful in mental health scenarios because it allows students to assess for nonverbal cueing that can be very telling in a lot of patients, particularly those that are having some behavioral concerns. So this gives them an opportunity to actually read those nonverbal cues from patients. Okay, so selection of the scenario, and this has been very nicely mapped out in all of our presentations today. But the scenario that we chose was prescription opioid abuse among older adults. So opioids are a class of drugs that can either be illicit, such as heroin, or illicit. These are our prescription drugs. These are our fentanyls and our oxycodones, oxycontins, and morphines. They're commonly prescribed, again, for chronic non-malignant pain. And we've seen a drastic increase in the use of these medications. Prescriptions of these drugs have increased from 76 million to 207 million between 1991 and 2013. From the CDC, they said providers write enough prescriptions for opioids that every American adult could have their own bottle of pills. So that's an astounding amount of prescription opioids that are available. And with this significant rise in prescription opioid availability has come its corresponding increase in their abuse and misuse. So again, as everyone has mentioned, there is a current opioid epidemic in this country. Approximately 2.1 Americans suffer from substance abuse disorder related to prescription opioids. And actually what I found was rather interesting was that the overdose death from prescription opioids was 20,000 around 20,000 in 2015, which was greater than the number of overdose deaths from heroin, which was only around 12,000. Substance abuse treatment for prescription opioids has increased sixfold between the years of 1999 and 2009. So why were we targeting the older adult population? Older adults are high consumers of medication, particularly substances like prescribed pain medications, because they usually have comorbid conditions or chronic conditions such as chronic pain that require prescription opioids to manage. So they are prime candidates for prescription opioids. But what we're finding is that many of these older adults are now using their prescription opiates to manage non-pain symptoms, or they're not taking their medications appropriately for non-medical reasons. 2.1 million older adults in 2012 reported non-medical use of their prescription drugs. And actually, the need to address prescription drug use in the older adult population, we've seen an increase from 0.7% to 3.5% in a number of individuals seeking specialized care for their prescription opioids that are of the older adult population. And it is expected that with the aging baby boomer population, this is going to continue to become an issue. We're going to see a larger increase in the older adult population, and we're expecting to see continued misuse and abuse of prescription opioids that are going to require some sort of intervention. Okay, so it's important to note that the teaching of the motivational interviewing was a small component of the overall study. As Dr. Compton talked about with the CDC recommendations, so we're looking at how do providers address prescription opioid abuse or any type of abuse in their population. So for us, we're training these, we have these nursing students that are eventually going to graduate to become advanced practice nurses. They're going to have the prescriptive authority to write prescription opioids. So with that responsibility comes the need to assess for any type of misuse and an intervention to address if we're identifying that these patients are misusing their prescriptions. So what we did was we developed an educational intervention to teach students how to identify or how to screen for prescription we focused on prescription opioid abuse, but we also talked about different screening tools for like alcohol and other substances, and then what to do about it. So part of our intervention is we're going to try and do motivational interviewing with the students. So we used opioid abusers that in a primary healthcare setting, so we acted as this was a primary care, and we asked the students to apply motivational interviewing techniques to address opioid abuse. And some of the techniques include developing discrepancies, showing empathy, reflective listening, change talk, assessing readiness and confidence, and supporting self-efficacy. So this was a feasibility study. So basically we were looking at to see if we could incorporate motivational interviewing training into the DNP curriculum, what effects would this have on student learning outcomes? How would the students react to a behavioral health simulation? And also, are we able to prepare standardized patients for the unpredictability of student responses? The design of the study was a small-scale study, one group pre-test, post-test design. We did a 3-part learning intervention that included didactic lecture, we did role-playing, and then we also did the standardized patient simulation. We did obtain IRB approval for this study. Outcome measures, we used a motivational interview and confidence scale just to look at students' confidence over the course of the intervention. We also used the motivational interviewing knowledge and attitude test, which is a tool that's useful in assessing knowledge and beliefs consistent with MI. So that was another one to assess knowledge. We also used the Behavioral Change Counseling Index, which is a tool to assess skill. And then the other thing we did was we did 3 different debriefing sessions with semi-structured interviews with the students that participated in the standardized patient scenarios. And then we also did open-ended questions that the students put in part of their checklist to assess their learning and what their thoughts were on the overall learning intervention. And this is actually a small clip of a student who's actually doing an interview with one of our standardized patients. This is a very good scenario because you see he's using some of the motivational interviewing skills. Some of these are assessing confidence, assessing readiness, helping to resolve ambivalence. He's also acknowledging previous successes. So I have to play. There we go.
How ready are you to try on a scale from 1 to 10?
So here he's assessing the readiness for change.
An 8. Mm-hmm. That's awesome. That's wonderful. Mm-hmm. An 8 is definitely a great place to start.
Okay.
Now, why an 8?
Well, I feel pretty ready, but I'm not totally sure.
No?
On a scale of what are we talking
You
about?
have 5 minutes remaining. 5 minutes.
Well, on a scale, 10 being ready to do this right now, right off the bat, and, and take this full steam, and 1 being not at all, I don't even want to try, I don't want to listen, I'm not going to read the paper.
Yeah, an 8.
You're an 8?
Right, because I'm not totally sure I can do it.
Not
but
totally
I
sure.
want to try.
Now, why are you not totally sure?
I've been doing this for a long time.
Yeah, okay.
We're looking at their resistance to change. What are their reasons for not wanting to change?
And why are you an 8 and not a 0?
Because I know I need to try.
Okay.
I need to preserve my health, and I need to try.
Identifying where their motivations lie.
So
I want to, yeah.
It sounds like you really want to do the best thing for your health, right? Okay. So now, on a scale from 1 to 10, how confident are you? Same scale. How confident are you that you can do this?
I'm like a 5.
A 5?
You know?
Now, why not an 8, like your readiness?
Just because it's such a habit. I've been doing it a long time, and I'm worried I'm not going to be able to, you know,
Okay.
even if I want to.
So, why not a 0?
That's something I feel like I have to do, and I've changed things before. So.
You have changed things before.
This
Now,
scenario was a chronic pain patient with knee pain. So if you can see, she's rubbing her knee a lot. We tried to incorporate some of those nonverbal cues, hoping the students would pick up on them.
And I gave up smoking.
He's acknowledging previous successes.
So that, you know, that gives me some confidence.
Perfect. So you've already been there.
Mm-hmm.
That's great. You've already been there and you've already made
Mm-hmm.
a significant life change.
Mm-hmm.
So
Okay.
now, coming full circle, do you think that maybe to implement these things, these new strategies,
Mm-hmm.
we can possibly incorporate some of those old strategies?
Mm-hmm.
Yeah?
Yeah.
Okay. So the student did a very good job at demonstrating some of these core motivational interviewing skills, but as you can see, he's far from an expert. He's far from being completely proficient and able to perform this on actual patients. So the goal of this training was not to say that these students are proficient and they can go out and use motivational interviewing training, because anyone who knows anything about motivational interviewing training knows that it's way more in depth and it requires a lot more than just a single point of contact or a single episode of training to really be proficient at it. But what we do see here is that we do have a student that is developing some of those skills. They have more awareness of those skills and they're able to actually demonstrate some of them. Here's my thing. Okay. So characteristics of the participants. So as far as their specialty, we had 45% that were in the family practitioner program. We had 19% that were in the adult practitioner program and 36% that were in the psychiatric practitioner program. As far as previous experiences, only 19.4% ever had any previous training with motivational interviewing. Very few, 9.7, had any experience with substance abuse, and 19.4% reported some experience with psychiatric nursing. None of them had had experience with a standardized patient scenario up until this point of their career with an actual patient. A lot of them have done with the dummies, but none with actual trained actors. So what we saw, and this is the top one, is the motivational interviewing knowledge and attitude test. So this is the tool that we use to look at knowledge over time. And we measured using one-way ANOVA. We looked at 3 different time points. We had a baseline before we had any intervention, after the didactic lecture, prior to the role playing, and then after the simulation experience. And what we see is that the students' knowledge actually increased. Statistically significant from the baseline data to the post-didactic and the baseline to the post-simulation. So we did see a small increase from the post-didactic to the post-standardized simulation, but really was not a real significant increase. And actually, as I go on to talk about some of the qualitative data that we obtained from the students, we kind of see why. As far as the confidence scale, so this kind of looks bad, but honestly, the smaller the number, the better, the more confident the students are reporting. So it's opposite. So students actually reported, significant increased confidence throughout the intervention. Again, between the post-didactic and the post-simulation, we saw a lot less or decrease in the numbers, which would mean increase in confidence. It definitely slowed down and was not statistically significant. But again, I'll talk about why we saw some of that. So the behavioral change scores. So this is basically a tool that we can use to look at skills. This is the items that we look at, and then we measure on a scale to see how students perform doing these skills. And what we saw is that students were able to actually demonstrate the skills. Where they weren't highly proficient, but they were able to demonstrate some of those core skills for motivational interviewing. Unfortunately, we don't have anything to compare this to. This was just done as a descriptive statistics after the fact, after we reviewed the students' standardized patient experience. But for the student feedback, so during the debriefing and some of the qualitative data we obtained from the students' comments, we found that this overwhelmingly positive feedback from the students. Students were able to demonstrate that they found value and meaning through the self-reflection. So a lot of the education is through the debriefing session. It was a stressful experience, but I feel I learned more about motivational interviewing by practicing it than I did just by reading it. So this brings up a very important point, the stress level. Students reported high stress before the standardized patient simulation. As I mentioned, they didn't have any experience previously with standardized patient simulation, so we feel like that stress may have played a factor in their confidence level and their ability in their knowledge level. They showed generalizability of knowledge. I think I could use motivational interviewing with my diabetic patients. They were also able to identify strengths and weaknesses. They did note recommendations for improvement, so they wanted more practice experience before simulation, and they wanted more time with their patients. And they were also able to identify gaps in knowledge and skills. So it was harder than I thought, but I was able to find out what I actually knew about substance abuse and motivational interviewing and what I still need to learn. So again, learning about it from a lecture is one thing, actually practicing the skills is another. So, and I think students found that out, which is why we didn't really see significantly increased scores in their knowledge and confidence, because the students were actually asked to perform these things. And as I mentioned previously, this isn't something that you can just pick up overnight. This is something that you really have to practice and you have continuing education and mentoring for. So the students were able to demonstrate and able to perform core motivational interviewing skills. We also noted increase in knowledge and confidence in regards to motivational interviewing. We did find that the experiential learning, the standardized patient simulation, was an effective educational method. And again, as I mentioned previously, learning motivational interviewing requires continued education. So this one brief scenario is not enough to make these students competent enough to go into practice and begin using this motivational interviewing. They need continued education and even mentoring after they get out of school with someone who's trained in motivational interviewing. Some limitations: non-experimental design, small scale. We didn't do any long-term follow-up to see about retention of education. And again, single exposure. So really what we need to do is we need to do multiple scenarios and multiple repeated exposure with standardized patients to really allow these students to practice their skills. So the study demonstrates that motivational interviewing can be implemented into a DNP curriculum, and that it did have a promising effect on knowledge, confidence, and skills. We are identifying some areas for improvement and does provide a foundation for future research. I would like to just acknowledge real quickly all the students that participated in the study. I'd like to acknowledge Dr. Chang, who led the study, Dr. Austin Ketch, Dr. Warnick, Dr. Scherer, all who participated in this study, and the funding source, the Health Foundation of Western and Central New York.